Hi, I'm Alan Gardner, Senior Lecturer for the School of Sport and Health Sciences here at the University of Central Lancashire, and thank you for listening to this video on heart failure. During this video, I will be exploring the mechanisms through which heart failure manifests. So we're going to be talking about the pathophysiology and etiology of heart failure and the way that these patients typically present. So we're going to actually apply that to a little bit of history taking and the physical examination of patients with heart failure. We're also going to start to try and understand some of the treatment options available for these patients, and we're going to be focusing mainly on chronic heart failure. To start with then, we need to define what we mean by heart failure. So from this definition here, we can see then that this is about the heart developing some sort of abnormality that renders it unable to effectively act as a pump. So it's unable to pump the required amount of blood that needs to be commensurate with the metabolic demands of the tissues that it's perfusing. So that the tissues in the rest of the body have a certain metabolic demand, and that needs to be met by the heart acting as a pump to send oxygen and nutrients to the tissues, and to be able to have some venous return. And when we get to that point that the heart's unable to perform that function anymore, then that's what we mean by heart failure. We can sort of further subcategorize these into diastolic and systolic heart failure. So what we mean by diastolic heart failure is when there isn't enough blood in the ventricles during diastole to meet that metabolic demand of the rest of the body. So essentially that's a filling problem. So in diastolic heart failure, there isn't enough blood filling into the heart, whereas in systolic heart failure, it's a pump failure. So in this case, the heart isn't able to effectively pump the required amount of blood out of the ventricles. That blood may well be there, but the heart's unable to act effectively to pump it out. Before we can understand the pathophysiology of heart failure, we need to make sure that we've recapped the normal anatomy of the heart and the circulatory system. So starting in the left atrium over here on this diagram on the left, we can see that we've got our arrows that indicate the direction of travel of our within our circulatory system. So from our left atrium, that drains through the mitral valve into the left ventricle, and it's the left ventricle's responsibility to pump blood through the aortic valve here and up the aorta into the systemic circulation. So it's going to travel in this direction, so we reach the systemic circulation where we're going to perfuse all the organs and tissues around the body, which then returns in our venous system through the inferior and superior vena cava and drains into the right atrium here. The right atrium then drains blood through the tricuspid valve here and into the right ventricle, where blood is pumped through the pulmonary valve and up the pulmonary arteries into the lungs, where it is then oxygenated and then returns through the pulmonary veins, of which there are 4 of them, which drains back into the left atrium. So we have this have our heart here that acts as a pump and needs to constantly pump blood through this the circulatory system, both systemically and into the pulmonary circuit up here. Now we can start to understand the pathophysiology of heart failure. So this is understood through a series of different adaptations. The first 3 of these are predominantly adaptations of the heart itself. So we can understand that in terms of the Starling mechanism, which we'll get onto in the next couple of slides. But this is a normal physiological mechanism that helps us to understand how we can regulate preload. And again, we'll get onto that shortly, what we mean by that. This is essentially our way of regulating the amount of blood within the ventricles and the amount of stretching of the cardiac myocytes, the muscle cells within the heart, how they're stretched in order to then provide the necessary contraction during each cardiac cycle. We also have myocardial hypertrophy, so this thickening or enlarging of the myocardium in response to increased demands on the heart. So, for example, in chronic systemic hypertension, that puts an increased demand on the heart, and therefore we need to that the heart ends up remodeling. That's also affected by this third one here, this idea of alterations in myocyte regeneration and death, which again we'll talk a bit more about shortly. Exterior to the heart, the activation of the neurohormonal systems. So in particular, the renin-angiotensin-aldosterone system, which again we've got a slide to discuss that and how that regulates blood pressure in response to increased demands during heart failure. So we'll talk about that shortly. Hemodynamics are the factors that affect the flow of blood through the heart and through the rest of the circulatory system. And by understanding the way that hemodynamics changes in response to increasing demands on the heart will help us understand the way that our body responds to this drive for adaptation that will lead to a compensatory mechanism. So during increased demands on the heart and on the cardiovascular system, our body will drive adaptations that help us to compensate, and you'll hear this term compensation. So for example, patients with chronic systemic hypertension or with aortic valve stenosis, our body, well, the heart in particular, will compensate to overcome these diseases. But in heart failure, we get to a point where those compensatory mechanisms are no longer effective, and we call that decompensation. So hemodynamics, then, as I say, will help us to understand how these adaptations are driven and how they change in response to these increasing demands. So we start off with this idea of cardiac output. Now, cardiac output is the volume of blood ejected by the left ventricle with every minute, and this is calculated as the heart rate multiplied by the stroke volume, and this gives us the cardiac output in milliliters per minute. So, for example, we have our typical resting heart rate of 60 beats per minute, and that one's fairly easy for us to understand. That's pretty simple. That's just the number of beats per minute. Whereas our stroke volume, as we can see below, is actually determined by three factors: our preload, afterload, and contractility. And I'm going to talk about each of those in turn. But by multiplying our heart rate by our stroke volume, and our typical stroke volume is 70 mils per beat, and that gives us a cardiac output of 4,200 mils per minute. What this is telling us, though, is that our stroke volume is affected by these three factors, and it's these three factors, the preload, afterload, and contractility, that are all they're all going to be affected by various pathophysiologies affecting the heart. So on the next slide, we'll start with we'll go through each of them in turn. So we'll start with preload, then afterload, then a little bit on contractility and how that changes due to underlying conditions that lead to heart failure. The first of these three concepts or factors that affect stroke volume then is preload, and we can understand this as the amount of stretch imposed on the myocardial tissue during diastole. So as the heart refills with blood, it needs to stretch the myocardial fibers in order to increase the force of contraction. So we can understand this a little bit like an elastic band. So as we stretch an elastic band and then release it, the greater the stretch, the stronger the force of contraction. The difference between the elastic band analogy and the myocardial fibers, though, is that the myocardial fibers are actively contracting, whereas an elastic band is just passively contracting. So it says here then that in practical terms, the more the heart is filled by blood during venous return, the greater the force of contraction, and so therefore we get an increased amount of blood ejected during systole. So we increase stroke volume by increasing the amount of stretch during preload. So we load the ventricle with more blood during diastole, therefore we can increase the amount of stretch on the myocardial fibers, therefore we can increase the amount of blood ejected with each contraction during systole. However, there are some limitations to this. So the more we stretch it, we can reach sort of an excessive amount of stretch. And so that is the point at which our actin and myosin filaments actually decrease the amount at which they overlap. So these are the two parts of the myocardial fiber that are involved in contraction. And so once they're sort of stretched too far, we actually then start to lose the force in contraction. And this is the point at which we reach heart failure. So actually, if we move to the next slide now, what we have is the Frank-Starling curve. Now, what this curve shows us is that we've got stroke volume up the y-axis, and then end diastolic volume along the x-axis. So as we increase end diastolic volume, so we have a greater amount of blood in the ventricles at the end of diastole, we can then, so actually if I draw this on here, so we're going along this x-axis here, this is leading to a greater amount of blood in the ventricle during diastole, and so if we get to this point here, we have a larger amount of blood here, therefore we have a larger stroke volume. But as we get to this point here, we can see that the curve is now starting to head downwards, and actually if we were to continue this, it would head downwards quite rapidly, and this is the point at which we have heart failure. So we've overfilled the ventricles with blood, overstretched the myocardial fibers, therefore we have a failure of the heart to act as a pump. So actually more specifically what we have there is systolic heart failure. At the other end of the scale, what we're seeing here is if we had too little end diastolic volume, so we don't have enough stretch of the myocardial fibers, therefore our stroke volume would be decreased. So what we would have here is diastolic heart failure. Okay, as I was saying before, this is a normal physiological mechanism through which our circulatory system can increase the amount of preload in order to increase stroke volume as a result of increased cardiac demands due to exercise or other illness. So we can compensate for increased demand around the body. Where it becomes pathological is when we are no longer able to for the heart to effectively act as a pump, and we get to this point here that we've mentioned before, which is heart failure. The second of the concepts affecting stroke volume is afterload. We can understand this as essentially this is the force opposing fiber shortening during ventricular ejection. So each time the heart contracts, as the ventricles contract, the heart needs to overcome a certain amount of resistance in order to open the aortic and pulmonary valves, and we refer to this as afterload. So it's the tension or pressure within the systemic circulation, so that would be the systemic vascular resistance, and that's impacted upon the left ventricle, or the pulmonary vascular resistance, which impacts on the right ventricle. So as we saw at the beginning of the video, we went through the cardiac anatomy, so we know that the left ventricle sends blood to the systemic circulation, and it needs to overcome an amount of resistance within that systemic circulation in order to open the aortic valve. We also saw that it's the right side of the heart, so the right ventricle, that pumps blood to the pulmonary system, so it needs to overcome that pulmonary vascular resistance in order to open the pulmonary valve. And what we can see in the chart on the right then is that we have our stroke volume up the y-axis, and then this is left ventricular end diastolic pressure on the x-axis. So as our left ventricular end diastolic pressure increases, this is a result of an increased afterload. So as afterload increases, we're actually left with a greater pressure within the left ventricle at the end of diastole, which means that our stroke volume decreases. So essentially, as we increase the force needed to open the aortic valve, so for example in hypertension, we're going to be left with a smaller stroke volume. Whereas if we look up here, when we have a decrease in afterload, so in the event of a decrease in the systemic vascular resistance, such as after the administration of drugs like ACE inhibitors, then we can actually decrease the afterload, which decreases the amount of effort needed to open the aortic valve. Therefore, we can increase stroke volume. The third of these factors is contractility, or this is often referred to as inotropy. And you'll have heard of the classification of drugs as inotropic drugs. So this is the physiological term for the heart muscle's ability to contract. And there's multiple things that could affect the ability of the myocardial cells to contract. For example, presence of myocardial infarction, and even post-MI, people are left with scarring, permanent scarring within the myocardial tissue. Next is myocyte regeneration and death. Now, in coronary artery disease, we have a decrease in blood supply to the myocardium, and in particular after myocardial infarction, which is essentially the end point of coronary artery disease, where we have this termination of blood supply to areas of the myocardium, therefore leading to cell necrosis. But during coronary artery disease, we have this increased regeneration of myocytes, leading to an increase in size of the myocardium itself, which we refer to as well, if it's the area around the left ventricle, then it's left ventricular hypertrophy, which is what we're seeing demonstrated in this this image on the right side of the screen. So in the presence of coronary artery disease, then we get this proliferation of myocytes, the cardiac muscle cells, and this itself is one of our adaptive responses to an increased demand on the heart. So in coronary artery disease, we have an increased demand of for oxygen and nutrients within the heart itself. So this leads to extensive remodeling of the left ventricle, and therefore cardiac muscle hypertrophy. And the cells, the actual myocytes themselves, tend to grow and enlarge. They themselves are hypertrophic. And this can also occur in disease in the absence of coronary artery disease. For example, aortic valve stenosis. We know that there's an increased pressure, an increased demand for the opening of the aortic valve, and we've talked about that in terms of afterload. So the heart needs a more forceful contraction to overcome the pressure exerted on the aortic valve, and it's the same in systemic hypertension. So this leads to this extensive remodeling of the cardiac myocardium. So although this is an adaptation for an increased demand on the heart, actually this in itself means that the heart tissue has an increased demand for oxygen and nutrition. Therefore, adaptation drives further demands. And as we mentioned when we were looking at the Frank-Starling curve, we said we got to a certain point where this adaptation then failed, and that's the point of decompensation, and that's when we get heart failure. So what we're talking about now then in terms of myocyte regeneration and death is actually when the heart's adaptation becomes so demanding in and of itself that it's no longer able to reach those demands as well as meet the demands of the rest of the body. So as the heart tissue grows larger and has a greater need for nutrition and oxygen, it can outstrip its own supply essentially, and so that's when we then start to, well, that's the point of heart failure. In the last few slides, we've explored the adaptations within the heart that contribute to the response to various pathophysiological mechanisms that drive an adaptation within the heart. So, for example, we've talked about systemic hypertension and aortic valve stenosis and how this puts an increased demand on the heart. We've talked about those 3 factors that affect stroke volume and how they can be regulated in a response to these adaptations. We've also got mechanisms outside the heart that are going to change and adapt in response to the increased demands on the heart and contribute to exacerbating heart failure. And a really important one is the renin-angiotensin-aldosterone system, the RAS system. So this is an important hormonal system that has a physiological role to play in regulating blood pressure, but it also has a pathophysiological mechanism in terms of its role in heart failure. So as the heart muscle starts to fail, we end up with reduced perfusion to our kidneys, and this reduced renal perfusion leads to an activation of the renin-angiotensin-aldosterone system. As we get a decrease in renal blood pressure, the kidney is stimulated to release renin, and as this is released into the systemic circulation, it acts on angiotensinogen, which is an enzyme released from the liver, and this forms angiotensin 1. We then have this angiotensin converting enzyme, which is released from the lungs. So this is abbreviated as ACE, and this is the point at which our ACE inhibitors work, and we'll talk about their role in treating heart failure shortly. But angiotensin converting enzyme then converts angiotensin 1 into angiotensin 2, which is responsible for vasoconstriction. And so what we can see on our diagram on the right is that when we have vasoconstriction, we end up with an increase in blood pressure, an increase in sympathetic tone of the circulatory system. We also retain sodium, and therefore we retain fluid. And in heart failure, this is actually initially a sympathetic response. So this is the body's way of actually driving an adaptation for that we have a drop in blood pressure. The kidney detects that there's a decrease in perfusion within the kidney, and so it's driving this this response. But the problem with this is that as we start to try and increase blood pressure, we increase the systemic vascular resistance. And when the heart is already failing to overcome that systemic vascular resistance, it's going to actually exacerbate the effects of heart failure. This starts to explain why we then see raised sodium levels, and we see fluid collection in patients with heart failure. So we know that they have peripheral and pulmonary edema, and that's because the RAS system is actually driving this retention of sodium and fluid. Moving on from the pathophysiology into the aetiology of heart failure, we can see that we have 3 main categories. Starting from the bottom, we've got genetics of cardiomyopathy. So these are hereditary conditions that are going to affect the heart's ability to perform its function as a pump. But we're going to talk mainly about the top two, which are the underlying causes and the precipitating causes. We need to understand then that our underlying causes can be divided into the causes of systolic heart failure and the cause of diastolic heart failure. However, what you'll see from these two lists is that there's quite a lot of overlap between the two. So we're saying that systolic heart failure is about a failure in the heart's ability to actually pump the amount of blood present within the ventricles around the rest of the body. So, for example, coronary artery disease, the heart needs to overcome the amount of pressure within the coronary arteries, and it needs to actually perfuse its own tissues in order to act effectively. Diabetes mellitus has this effect of microvascular disease, therefore increasing peripheral vascular resistance, as systemic hypertension does as well. But systemic hypertension tends to act more on the larger vessels, where we have deposits of atherosclerosis in the arteries and larger arterioles. Valvular heart disease, and we've already mentioned aortic stenosis. These diseases of the heart valves themselves can lead to the failure of the heart to act effectively as a pump. So if it's unable to produce enough force to overcome the stenotic valves, or if we have some regurgitation. So as we looked at the cardiac anatomy earlier, we saw that we've got this unidirectional pump. In regurgitating lesions, we have essentially backflow of blood through the various valves. So that decreases the efficiency of the heart, and over time that's again going to drive this adaptation that at some point will decompensate, therefore leading to heart failure. Just as arrhythmias and infections and inflammation such as myocarditis can lead to this failure of the heart to act as a pump. When we get to these causes of diastolic heart failure, remember we said earlier that diastolic heart failure is that failure of filling the heart in the first place, so we don't get enough blood draining into the heart during diastole. So again, with thinking about coronary artery disease and its role there, that in hypertension we'll have this decreased filling of the heart during diastole, just as we do in valvular diseases as well. Precipitating causes. Now what we mean here then, this is factors that can actually cause an already compensated heart to fail, and this might be for the first time, or it might be causes that actually lead to a patient with chronic heart failure to need to be hospitalized, so an exacerbation of an already recognized heart failure patient. So one of the main things that we need to be aware of then is that this might be an inappropriate reduction in treatment. So when we get to the management slides a little later in this presentation, we'll talk about the importance of dietary restriction of sodium. We've already mentioned why in terms of our RAS system that we mentioned a little earlier. So the RAS system is going to drive retention of sodium, so we need to decrease the amount of sodium that patients are taking in as part of their diet. And if as a precipitating cause then, I mean, what might cause people to take in more dietary sodium? Well, that might include an absence of effective patient education. It might be that they just have become disheartened with their management, and so they just decided that actually they're a bit fed up with it and they want to eat some foods that they miss. We know that that happens, just as that can happen with our physical activity reduction as well. But that it might not just be because people are fed up with their treatment or don't want to continue with any sort of exercise regime. It could be that they're inactive due to other illnesses, and that could be something simple, just as a cold or other viral infection. And it's the same with a drug regimen as well. So if they're taking medications such as ACE inhibitors, which we'll talk about shortly, that again might be due to a lack of patient education if the prescription hasn't been explained effectively at the point of issue, or it might just be because we know that people fluctuate in terms of their concordance with drug regimes. If people develop arrhythmias, that's going to exacerbate heart failure in an otherwise stable patient, and in particular, ventricular arrhythmias can be particularly life-threatening. Systemic infection itself is also another precipitating cause, so that might just increase the demand on the heart, therefore tipping them into heart failure. There's other high demand states as well, such as profound anemia or respiratory heart disease. So this is classically referred to as cor pulmonale, which is when we have an increased pressure within the pulmonary circulatory system, such as during pulmonary embolism or pulmonary fibrosis. That's going to actually increase that vascular resistance. So the pulmonary vascular resistance goes up, therefore it's going to increase our afterload, therefore decreasing our stroke volume, which may lead to heart failure. But also pregnancy is another high demand state, as is thyrotoxicosis. So they're just a small selection of things for us to look out for in terms of our precipitating causes of heart failure. We can now move on to our diagnosis, and this is going to start with our history. And we've got some key symptoms to watch out for. Now, a typical heart failure patient will present usually with something like a complaint of breathlessness. So this might be new onset exertional dyspnea, and we're particularly looking out for dyspnea at rest. And we can measure this through our New York Heart Association scale. So we've got classes 1 through to 4, with 1 being no limitation of physical activity due to their breathlessness, all the way through to class 4, which is this inability to carry out any sort of physical activity without any sort of discomfort. They're going to have symptoms at rest. So even just standing up out of a chair might be enough to leave them really breathless. And then obviously classes 2 and 3 in between. And on the next slide, we'll see how this New York Heart Association scale plays into the ACC and AHA staging system. But as we're taking our history from patients, we need to explore their level of breathlessness and try and use these scales as a way to sort of gauge the level of limitation due to breathlessness. Now, they might be breathless at night, which can be characterized as this paroxysmal nocturnal dyspnea, where people tend to wake up suddenly really breathless. And this is because as people with heart failure lie down over a sort of matter of minutes to hours, they'll get this pooling of fluid. Obviously, as we're stood up, it's more likely to pool with gravity down towards our lower extremities, whereas if we're lying flat, it might pool within our lungs, therefore decreasing the amount of surface area that we have for gas exchange. And so people will wake up with this sudden sensation of breathlessness. They might need to go to the window for this feeling of needing to get some fresh air, and that will then sort of settle as they're resting, unless they're already very breathless at rest anyway. Now that's different to sort of just typical orthopnea, which is just breathlessness lying flat anyway. So as part of our history, we can ask people, are you waking up feeling breathless, or are you unable to lie flat whatsoever? In which case some people will be propping themselves up with pillows rather than lying flat. Some people may present with chest pain or a pressure type feeling in the chest, or even palpitations, which is this sensation, like an unpleasant sensation of your own heartbeat. They may present with some fatigue and weakness, some urination through the night, or profuse urination, which is oliguria. They may have some nausea and weight loss with it as well. As we move on to the next slide, then we can see how our New York Health Association classification plays into the staging according to the American College of Cardiology and American Heart Association classification staging. So stage A is when there's risk factors in place, so if people have a pre-existing diagnosis of coronary artery disease or systemic hypertension, any valvular disease, that they have risk factors for heart failure in place, but no actual structural heart failure as yet. Moving through to stage D, where they have refractory or well-defined, well-diagnosed heart failure. Moving into our physical examination, signs that we're looking for in order to help us diagnose heart failure include acute pulmonary edema. So people with new onset acute heart failure are likely to have harsh crackles, particularly around the lung bases. It might be that they have them throughout their lung fields, but thinking about the way that gravity will pull pulmonary edema is likely to be in the lung bases, if anywhere. They're likely to present with tachycardia and some bulging of the eyes, which is this exophthalmos, or you might be able to see a visible pulsation within the eye. And this is because of the heart's inability to effectively continue to pump blood around the body. We get some pooling within the venous circulation, which leads us to this raised JVP here, which stands for jugular venous pulsation. We're probably used to measuring that as jugular venous pressure. If any of you work in critical care environments, you'll work with patients who have central venous pressure lines in place, so that's an invasive way to measure jugular venous pressure. However, with jugular venous pulsation, what we can see is in this gentleman on the right, the arrow is pointing toward distended neck veins. And although we're used to seeing arterial pulsations, we can actually measure a jugular venous pulsation, which has different characteristics. For example, within this area, actually, if let's see if I can just draw this on. So we've also got our carotid artery in the same area here. Now, the common carotid artery travels up the neck, where it actually bifurcates into the internal and external carotid artery. But what we're seeing is this distended internal jugular vein here. Now, a carotid arterial pulse will just have a single peak. So if we can see a carotid arterial pulse, it will just have this single peak, whereas a venous pulse is defined as having a sort of a double peak, so it'll be like kind of boom, 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 boom. There are videos on YouTube that you can watch to see a jugular venous pulsation. We can also collapse a jugular venous pulse. So as we palpate that with our fingers, it should collapse underneath, whereas a carotid pulsation wouldn't be collapsible. It also mentions here then this idea of a hepatojugular reflux. Now we can actually accentuate a raised jugular venous pulsation by depressing the liver within the abdomen. So in the right hypochondria, we can actually just squeeze the liver essentially, and that causes this reflux of blood up into the right internal jugular vein, therefore sort of increasing the height of the jugular venous pulsation. Moving on then, we might also see a weak, rapid and thready pulse. Patients may have wheeze or crepitations on respiratory examination. We have this S3 gallop. Now this is one of our heart sounds that we might be able to identify. So if you are used to listening to heart sounds, then you'll be used to heart sound 1 and 2, which is just the healthy lub-dub sound that we hear that denotes the closure of those 4 valves that we talked about earlier. Now our S3 gallop, it's in addition to our heart sounds 1 and 2, and it's said to sound with the same cadence as the word Kentucky. So we get this Kentucky, Kentucky, Kentucky sort of gallop type sound, which is thought to actually be caused by the oscillation of blood that remains in the left ventricle during with heart failure. So after systolic contraction of the cardiac muscle, we get like a residual end diastolic volume that we can actually hear as this third heart sound. So we get, instead of just a lub-dub sound on auscultation, we get this Kentucky gallop. And if you go to my YouTube site, you can see there's another video on examination of the cardiovascular system in general, if you want to know a bit more about that. Our Framingham criteria will help us to diagnose heart failure. So we've got our major and minor criteria, and the framing criteria says that with two minor, or one major and two minor criteria, that we can diagnose heart failure. So just to sort of use this as at-a-glance information that will help you with interpreting your history and exam findings in order to decide whether or not to diagnose heart failure. So for example, if a patient has paroxysmal nocturnal dyspnea and neck vein distension, then they have two major criteria, and this is going to give us a high indication of suspicion for heart failure. Whereas if they were to have the third heart sound, so we've got this S3 heart gallop here, and then two of our minor criteria such as tachycardia and a nocturnal cough, then that might equally increase our suspicion of heart failure. Moving on from the diagnosis, then we can go into our medical management of chronic heart failure, which is essentially about modifying our renin-angiotensin aldosterone system, decreasing cardiac output, and decreasing cardiac remodeling. So they're kind of the three targets of our long-term treatment of heart failure. We know that our angiotensin converting enzyme inhibitors, so our ACE inhibitors, are our first-line treatment for patients with left ventricular dysfunction, even without symptoms. So these have actually been shown to vastly decrease risk of MI and risk of death in patients with symptoms of heart failure. Moving on to our next slide, we know that beta blockers such as metoprolol, bisoprolol, and carvedilol may be really useful in reducing hospital admissions and preventing disease progression alongside ACE inhibitors, and they have been demonstrated to have to improve long-term survival in heart failure patients after ischemic events. For patients who need more symptomatic control, even though they're taking ACE inhibitors and beta blockers, diuretics can be really helpful to combat that fluid retention that we mentioned earlier as part of the RAS sympathetic approach that actually leads to become more problematic. So diuretics will be useful to help them to get rid of any excess fluid. We know that digoxin is also useful for patients that are taking all the above. So we've essentially got this sort of laddering effect where we start with ACE inhibitors, then we can have beta blockers, and then diuretics, and then digoxin. We've also got some non-pharmacological therapies as well. So exercise and nutrition. We mentioned earlier that the RAS system leads to retention of sodium. So we need to restrict dietary sodium, and this is generally to 2 to 3 grams per day. There's also evidence to suggest that restricting activity is going to promote physical deconditioning. So essentially we need to encourage patients to be more active. This is going to be within certain limitations, so we don't want people to be doing heavy labor or really exhaustive sports, because that's going to just put too much stress on their heart. So they need to have a program of activity that's manageable but isn't going to push them to their extremes, and a program of cardiovascular activities, so aerobic activities like strenuous walking or jogging as appropriate to the patient is going to be more effective than strength training. So it needs to be things that are going to push the cardiovascular system rather than strength training, so things like lifting weights, that sort of thing. And there's certain surgical interventions that may be available to some patients as well. So in particular, people who have heart failure as a result of valvular heart disease, if that's the underlying cause, then it's likely that they may be appropriate for aortic valve replacement. This can be done either as an open cardiothoracic surgery or for older patients and people with multiple comorbidities that are more frail. This can be done transarterially now as a TAVI. There's also devices for electrophysiologic intervention, and this includes pacemakers, cardiac resynchronization devices, and implantable cardioverter defibrillators. The image that we can see on the left is a diagram that represents a ventricular assist device. So this is an implantable device that actually drains blood out of the failing ventricle and then assists to pump it into what we can see here is that it's being pumped directly into the aorta. So this relieves the heart of some of its burden and actually assists in the heart's function as a pump. The real end point surgically is heart transplant. So for patients who have end-stage heart failure and will otherwise die, then heart transplant will become the only option for them. So actually, the final slide after this is my references. So this brings me to the end of this video on heart failure, where we've looked at the pathophysiological mechanisms that are at play. So we've looked at hemodynamics and how they change in response to an increasing demand on the heart. So we've talked about preload, afterload, and contractility, and how these physiological responses can help us to increase stroke volume. This is a physiological response, but that they have certain limitations to their adaptations, and it's when we reach those limitations that we then have heart failure. We've also seen how the renin-angiotensin-aldosterone system has a sympathetic response during heart failure, but that in itself becomes problematic because it increases the burden on the heart, therefore exacerbating the heart failure syndrome. We've looked at how to diagnose heart failure, so elements of the history and the examination are important, and then some of the common interventions that you'll see. So I'll move on to the references. I'd like to take this opportunity to thank you very much for listening, and please feel free to check out any other videos that are on my page. Thank you very much.